Hello, everybody. Welcome to the session, latest for transplant families and infectious disease stewardship. I'm Katrina Fields. I am on the transplant family board. I am a VAD coordinator at Cincinnati Children's Hospital, and more importantly, I am a mother to a kidney transplant recipient. To introduce our speaker for the day, Dr. Jason Newland is a pediatric infectious disease physician at St. Louis Children's Hospital and the director of the antimicrobial stewardship program. He developed a large national collaborative of the antibiotic stewardship program, SHARPS Collaborative. And with that, please take it away.
Great. Katrina, thank you, Melissa, Joe, to this whole amazing organization. I'm so honored to be here. I was telling Katrina and Melissa, I was like, this is like, I was wondering that it's such well done. It's the best Zoom sort of event I've ever been a part of. So just thank you. And I'm happy to share kind of some thoughts with you guys for the next 25, 30 minutes. And, I could talk infectious diseases for hours. And so I won't do that, but, if you have questions or comments, please don't hesitate to contact me. There's a Twitter, but I'll give my email. I'd love to help you. Here's some pictures of one's a petri dish that got us started with antibiotics. The middle one's my youngest daughter, who now is 17. And the far right picture is my family with my kids and my wife and my parents in San Antonio this past fall. So family matters. And so it is really an honor. It's a huge honor to be with you. Now I'm sitting in a VRBO or Verbo, as I think I'm supposed to say, in Washington, D.C., about to go to a Pediatric Academic Society meeting. And I hope for you all, eventually you guys can get back in person as well, because I know how important it is to be around each other. I have some number of disclosures around some work that we did during the pandemic, but also around some antibiotics. You guys and being families and parents, caregivers of those young ones that have gone through transplants know how important antimicrobials or antibiotics are. And so I want to kind of acknowledge that for you all, and let you know that we are trying to continue to do work so that we have more antimicrobials or antibiotics in case you need others that we don't currently have. All right, so I'm going to tell you a story. I like to tell stories, and the first story I want to tell you is actually based off a publication written back in the 1920s, really 1940s. And it's a story that, these publications back then were really illustrative and had a lot of words in it. And I received this from a colleague of mine when I first moved to St. Louis in 2016. And you can see I titled the slide as Pre-Antibiotic Era, because in 1921, the primary author, Jay Somowise, he's writing it from his perspective. And he says, look, at 13, I developed these movements called choreiform. Now, you guys, maybe some of you do know this, but choreiform is these dance-like movements. They kind of have these dance-like movements. And whether it's 1921 or it's 2023, if we hear someone has choreiform movements, the first thing that all of us think of in medicine is, oh, they have rheumatic fever, right? This entity known that comes from group A strep, or that causes strep throat, a common bacteria. And if you've been around in this past, think about this past fall and this winter, man, we've been seeing a lot of group A strep. This bacteria causing sore throats, but also getting in the bloodstream, getting in the lungs. causing bad stuff. So group A strep is common. But the biggest thing people are worried about is rheumatic fever, because what rheumatic fever can do is it can impact your heart. So in this story, this author is writing and says, look, in 10 years later, after being diagnosed with rheumatic fever and getting through some rheumatism, where he knew that he had kind of his aorta. So many of you I know probably have some heart transplant recipients, that aorta and the valve, the aortic valve was impacted by this rheumatic fever. Your own body kind of attacks it. And he says in 1931, writes in his paper, he sees these petechiae, or red dots on his wrist that don't blanch, right? So if I push on the red dots, they don't go away. He sees them and he says, I shall be dead in 6 months. Some big words, right? Say, I'm going to be dead in 6 months. In 1931, now mind you, in 1931, we didn't have antibiotics. Really, we had maybe sulfa drugs, but we didn't have antibiotics. Well, he said that because he knew he had something that he had endocarditis. Because endocarditis means he had an infection of his heart valve. And if you had endocarditis, an infection of your heart valve in 1931, you died. That's what happened. You died. And he relates this story. He actually talked about 2 or 3 other people that he knew peripherally that had died. Now, why I can tell you he had endocarditis, because they finally got a blood culture that grew a bacteria called Streptococcus viridans. In my line of work, if someone has a heart condition and they grow Streptococcus viridans, we worry about them having bacteria or an infection on their heart valves or involved in their heart. Scary. And here's his quote in the paper. He says, I could always find a loophole in the evidence here and there, but now I was confronted with a dictum ultimatum from which there was no escape. Again, he knew he was going to die. And actually, he doesn't finish the paper. It's his mentor finishes the paper and says, look, 3 months later, this individual developed aphasia, couldn't talk. He had a stroke in his brain because he basically shot up the infection into his brain. And he died. He died of pneumonia. Again, prior to antibiotics. Now, I tell you this story because not a week after I had this, I was in our cardiac intensive care unit. And I realized some of you probably have spent time in the cardiac intensive care unit. You know that this is an unbelievable place. The medicine that can be done, the fact that I am talking to a group of people that have experienced transplant, that have family members that transplant, kids that have been transplanted, demonstrates how incredible medicine is. Here I am walking through this unit, right? And we had a baby that I was seeing because they had 1 ventricle, right? You're supposed to have 2 ventricles. Maybe some of you have gotten transplanted because your child had 1 ventricle, right? 2, you're supposed to have 2. And this baby had gone through a surgery so that they can live and survive and thrive, which we know they can. And I was being consulted as an infectious diseases doctor to take care of a Streptococcus viridans found in the blood. Yeah, we treated this kid as endocarditis, and I didn't worry one bit about the ability to treat this patient. No, we treated for 6 weeks. The baby did fine, had another surgery, and is thriving. Many of these stories, some of you probably have experienced these stories. The fact that we can do transplantation is large because we have antibiotics. And antibiotics started coming into the market in the 1940s with penicillin is really sulfa first, then penicillin, and penicillin was really the revolution, many would say, in medicine around the antimicrobial era, which has allowed us to do transplants. We can give antibiotics to prevent infections. You guys know it's probably, you can tell me all about receiving Bactrim or your kids taking Bactrim 3 times a week to prevent pneumocystis, which you all know about. You could teach me about. Now, this is important because recently, these are recent publications talking about this, and many of you probably know this, right? In March 21st, 2023, deadly fungal infection spreading at an alarming rate, CDC says. That's Candida auris. We've seen it in the hospital setting. It's resistant to a lot of our antifungals. And those with underlying conditions and are immunocompromised are the ones we worry about the most. You guys know this. You experience this worry. This is likely a result of, some will say climate change, which is probably somewhat true, but also because we have antimicrobials and we're changing things. And we're seeing the resistance because these organisms, like fungus, like bacteria, they evolve quickly, and there's a lot of them. The story below, 2 additional deaths linked to bacteria and recalled eye drops. So if you've been following, this is the artificial tears from a couple of companies, been found in kind of long-term care facilities. There have been 68, as the last I looked, 3 deaths, 12 people have lost vision. 4 people have had their eye removed because of this infection. Now you're saying, Jason, well, what's this infection? Pseudomonas aeruginosa. So the bacteria called Pseudomonas, again, there's probably a few of you out there that know all about Pseudomonas. If you're cystic fibrosis and have had a lung transplant, you definitely know about Pseudomonas. Well, this Pseudomonas aeruginosa, this bacteria that's found in the water, found in our environment, was found in some artificial tears. Well, you're saying, Jason, well, why does that matter? Don't we have antibiotics? Yeah, we have antibiotics, but in this Pseudomonas aeruginosa has never been seen anywhere else in the world. And why do I say, well, when you look at the antibiotics that will work against this bacteria, none of them work except one. Let me say that again. None of the antibiotics we traditionally use worked against the Pseudomonas except one, which is the newest antibiotic that was approved in 2019, right? 4 years ago. And that antibiotic is called ceftriaxone. Scary. It's in our environment. It's here. It's a touch. So this is antibiotic resistance at its finest. It's happening. It's changing. And we have to figure out how we're going to do to help that. This matters because we know the CDC threat report, the most recent one in 2019, suggests 35,000 Americans, this isn't worldwide, die annually from an antibiotic-resistant infection. Reports suggest maybe up to 150,000, it's probably somewhere in between. 2.8 million are infected annually with antibiotic-resistant infections. When I say antibiotic-resistant infections, I'm talking MRSA, methicillin-resistant Staph aureus, and then like gram-negatives, these pink things we see that cause urinary tract infections like E. coli, Klebsiella. Some of them are multi-drug resistant, meaning they're resistant to like common antibiotics. These are scary, and we're seeing more of them. And then C. diff, maybe some of you have had to experience that awful disease. That's a complication of receiving antibiotics. That's your major risk factors. You get antibiotics, you can get C. diff. Again, it's hard. Antibiotics are important. Antibiotics are allowed us to be able to have this conversation with you all today because we can do transplants because we have antibiotics. It's important. It's a hard thing to do, but we have to do it together. All right, I'm going to tell you this quick story, 10 minutes in. This is a scary slide, all right? And I think it's important for us to think about. I'm going to tell a story now. So in this slide, these are older papers. Inadequate antibiotic therapy increases mortality, right? So on the y-axis, you have the percent mortality, and then you have this light blue, adequate therapy, darker blue or purple, inadequate therapy. And then you have these two studies. That means if you have bacteria in your blood, bloodstream infections, and then these three studies that if you have bacteria in your lungs and really in the ICU setting. And it is clear, we don't have to really talk more, but if you have inadequate antibiotic therapy, you die more, right? If you have bacteria in your blood, your body. Now let me just tell you a story. Let's think of the 5-year-old with acute lymphoblastic leukemia, right? I'm just going to give you ALL as it's a condition that we have a survival rate of 95%. I could take one of your transplant kiddos that has a central line. I can use that, right? One of these lines that goes into the heart. And maybe you guys have probably all experienced that. And we can use that. And you're at home, you're doing fine. In either case, we know we can keep you guys alive and do great. Well, let's just say all of a sudden this child has low blood pressure, isn't behaving right. You take him in the hospital, like, oh my gosh, the heart rate's up, the low blood pressure, they're breathing fast, and everyone's scared. You guys have been there. You know how it is. It's scary. On the medical side, we all know what we're going to do. If there's someone that runs into our emergency department or we see them, what to do, right? We're going to get blood cultures. We're going to give them fluids. If we need to give them blood pressure support, we're going to give medicines for that. And we're going to start antibiotics. And before we start antibiotics, again, we're going to do all these tests to see what the bacteria is. Okay. So you're like, okay, Jason, what's that regimen that we do? Well, we might do vancomycin and cefepime. We might do vancomycin and meropenem. What I'm telling you is names of drugs that doesn't matter. Many of you probably know, but these are the antibiotics that people like me says, you better start because we can't miss, right? I can't be wrong. I cannot be wrong in a child like this with picking which antibiotic to use against the bacteria I think might be there. Point being is I don't know what this child has, but I know the fact that they have a central line and they look like this. I have to be worried about bacteria being in the blood. All right. So the next question is, well, when do I know whether or not I'm right in the choice of that antibiotic? Well, in some cases, you might know in 8 hours because we've had some rapid diagnostic tests that once the blood culture grows, which will take about 6 to 8 hours at best case scenario, that I put it on a machine that says, okay, yeah, this is resistant to certain antibiotics, so you need to use something different. Okay, great. I can do that. But what if you're at a place that doesn't have that? What if you're from where I grew up, Altus, Oklahoma, small town, about 20,000 people, and you went to that local ER and they basically did all this stuff and they sent you to Oklahoma City because you got to be taken care of at a bigger center, right? There's people out there. They're not going to have that rapid test. So it might take you actually up to 30 hours to know whether or not you had that Pseudomonas I just described that's circulating in long-term care facilities we haven't seen somewhere else. In that case, we're wrong. And you can see why these slides, increase in death, happens. Resistance changes things. We have to be on board. We have to be doing a lot of things. We have to develop the tests so that we can identify infections quick and we know if they're resistant or not. We got to develop new antibiotics. I'm sorry, guys, as much as I hope we can keep antibiotics around and all the ones we have forever, hopefully some, yeah, but we're going to have to keep developing more. And there's not a market for it. We have to have new antibiotics. All of us have to use our antibiotics better. meaning we use it when we need it. We can't use it for colds all the time, right? If it's a cold, we can't use it. It's not needed for a cold, but we need to use it to protect those who have immune systems that aren't normal, right? So we need to have Bactrums to prevent pneumocystis. We need to have drugs that we can use to prevent infections. Like when you do have a transplant and you need to get the new heart, we give an antibiotic prior to that, right? So we prevent the surgical site infection that could be life-changing or actually lead to death if we can't prevent an infection at time of surgery. So we have solutions to this problem, but it's going to take a lot of things to do. One is we have to support new antimicrobial development. There's a law going through Congress right now called the Pasteur Act that would decouple this, meaning decouple the fact that we have to sell more of these really niche antibiotics, right? That makes it not dependent upon the number of drugs we sell. We got to have programs I'm going to describe called antimicrobial stewardship programs, which monitor the use of antibiotics within the hospital. So at our hospital, if you are started on an antibiotic, you have me and a pharmacist looking to see if we're using them appropriately, making sure we use the right duration of therapy, making sure we're diagnosing infections. This better diagnostics, know the best lengths of therapy. As you all know, we pick football scores, right? 7, 10, 14, or number of fingers and toes, 5, 10. We don't know. And you guys have all been taught, and all of us have been taught, oh, if I get my antibiotics, I need to take all of it so it prevents resistance. Well, the reality is I want you to take all your antibiotics so you don't have it lying around later to take when you think you need it, when you probably maybe don't need it. That's tricky, right? Those are tricky. We need to know the best lengths of therapy so we treat the infection and limit the amount of resistance. We need to reduce infections. So when you're in the hospital, we need to reduce a surgical site infection. We need to reduce that central line infection. We need to reduce, if you have a urinary catheter, that infection. Vaccination is key. And then I could talk for hours on antimicrobial use in the agriculture industry, and I won't bore you to death with that one. All right, so what is this antimicrobial stewardship? Here's the definition: optimal selection of the drug, of the dose, of the duration, so we have less toxicity for the patient, for your children, for your family members, for you, but we treat the infection. We don't help contribute more to resistance if we don't have to. The reality is it's the 4 rights: right drug, right dose, at the right time, for the right duration. Timing matters with surgical sites as well as if someone's septic. You got to get it in within 3 hours, the right drug within 3 hours. So we have a number of strategies. All the hospitals that you guys are going to and being taken care of will use these strategies. One is guidances. So just guidelines around how I'm going to treat pneumonia, or empiric antibiotic guidelines. So if I have someone coming in with sepsis, here's the drugs that we use. So we have them, we know, we base it on the data we have in our hospitals. These are things, surgical prophylaxis guidelines. So if you're going to have the heart transplant, what drug do we use to prevent the most common causes of surgical site infection for that? And we make sure we do it right. Having these guidances in place helps us make sure we have systems that make sure you all get the right antibiotics at the right time for the right duration at the right dose. We have these other programs called prospective audit with feedback, meaning us, like I was just explaining, in our hospital and many of your hospitals you take your children to, they have a program where, again, they let the clinicians order the antibiotics, and then they have a team, usually an ID doctor and an ID pharmacist or an ID nurse practitioner, that will review those and help the team, really collaborate with the team to make sure we're using the antibiotics correctly. Now, in some cases, we make sure that they call us before they start an antibiotic, like these bigger antibiotics, because we know that they have a niche and we don't want to use them up so we can't use them in the future. And then lastly, I mentioned this before, we need to prevent infection with vaccines, hand hygiene. The more we can vaccinate, not only ourselves, but our kids and those around the kids that are at highest risk, the less we'll have infections. If you don't get influenza, you're less likely to go into the doctor, who then is like, oh gosh, you're febrile, you're sick, I got to use an antibiotic because you look like you have pneumonia that could be bacterial. It's appropriate treatment, but if we prevent the illness altogether, we don't need to do that. So we also can do diagnostic strategies, and you see there's a lot of appropriate. So we got to use blood cultures appropriately. We're seeing in some of our ICU settings where, oh, someone has a fever and it's their 6th day of fever because they're going through this, maybe a bone marrow transplant. Maybe they don't need a blood culture. And we have a contamination rate of blood cultures. Respiratory cultures. If you remember your ICU days when your children had breathing tubes, potentially, they might have grabbed a culture off that tracheal aspirate. Maybe because they just didn't act right. Well, sometimes that drives some antibiotic use that they didn't need. And then using urine cultures. Again, all of these things, it's harder, right? You're like, well, don't we need to check? Well, yeah, in the right time. This is always tricky. All right, this is one I really want you to pay attention to. So penicillin allergy. We know that about 10% of the US population reports a penicillin allergy. We also know that often that allergy gets labeled when they're children, prior to the age of 10. We also know that of these people that have an allergy, about 95% is negative. They don't. It's about 5%, if not less, have a true allergy, meaning you got penicillin and then they had like hives, hard time breathing. Like, oh, that's the type of allergy. Yeah, there's a number of kids that might get, 5 days in their amoxicillin, get a rash. Well, that's probably just an adverse event. It's not necessarily an allergy, and they can get it. Now, you're like, well, Jason, why does it matter? Does this really hurt anybody if you have an allergy? Don't we have other antibiotics? Well, unfortunately, the data has come and it continues to show that if you have a label of a penicillin allergy, especially as an adult, you have a longer length of stay. You have a higher cost of care. You have this higher rates of MRSA, that methicillin-resistant Staph aureus. You have higher rates of the C. diff, that diarrheal illness that's awful. You have higher rates of surgical side effects because you're not getting the right antibiotic. You won't get the cefazolin or the ANSA for the surgical prophylaxis. You'll get something like clindamycin, which is inferior. And lastly, a higher all-cause mortality, which, because you're potentially losing a whole group of antibiotics that people are scared to give. So if we can make sure people that say they have an allergy really have an allergy and only diagnose us when we need it, that will impact people's lives. So if you have someone that has a penicillin allergy, I would go back and double check. We also know that 10 years past your allergy, you likely don't have a penicillin allergy anymore. So here, what can you do? Well, understand and know what antibiotics are being used to treat. Don't need to treat colds, need to receive antibiotic prophylaxis. Antibiotics are good. Antibiotics have allowed us to be able to do transplants. Antibiotics allows me to be able to have this awesome experience talking to you all, meeting your organization, how they put on this amazing conference. So I don't want you to take away that, but we got to use them better. Some tests aren't needed, and we need to understand if people truly have a penicillin allergy. And then finally, ask questions. You all know this. You all the best at it. Keep asking, especially around antibiotics. Do I really need that? Why am I using that antibiotic? What do you think about this? I understand this antibiotic resistance is a problem. Keep asking those. I'm telling you, we'll all love it. All right, I'm going to shift gears because, you got to talk about, I'm an ID doctor. You got to talk about respiratory viruses because COVID-19 changed all our lives dramatically, including mine. But also just to say, hey, influenza and RSV and more, there's a ton of these respiratory viruses, and we've all experienced them like crazy especially this past fall and winter. All right, so you should know, and you probably know, influenza mortality has been as high as 50,000 lives in the U.S. annually over 10 years. Now, during the pandemic, we didn't see as much, and it has been known to kill up to 200 children a year. That's a year. COVID-19 in 3 years killed 1,800, about maybe a little bit more of 1,800 children, right? And we know it's killed over 1 million, and this is all in the U.S. RSV caused up to 10,000 deaths, predominantly in individuals 65 and older, but 100 to 300 deaths in children. These are three important viruses that circulate every year, and COVID is just always going to circulate. We should all be prepared for that. So what we know with flu is vaccines matter. We know flu prevents millions of illnesses, and flu-related diseases each year. It reduces antibiotic use. It reduces children's risk of severe life-threatening influenza, reduces mortality. And we also know that if you, as a healthy individual that have someone at a higher risk for severe disease, gets vaccinated, you're going to help protect them. So it really behooves all of us to get our flu vaccine because we're going to protect those that are at greatest risk. And so I think it's super important. COVID. Now, there are a lot of data that continue to show that staying up to date with COVID vaccine helps protect us. Now, even if you've been infected, keeping up to date matters, and there's even more data. This is just during Omicron, where you have these three different age groups: 18 to 49, 50 to 64, greater than 65. This is rate of death per 100,000 population. You can see if you're unvaccinated, you're always the top line in all of these age groups. If you're unvaccinated, you're always at greater risk. But if you're vaccinated without boost, which is this middle, you had 2.5 times more likely to die. And then, unfortunately, we saw that sometimes we had some vaccinated breakthroughs. And those were those in the older population and 3 or more medical conditions. So being vaccinated matters. I think we're going to hear the story, and it's going to be told that actually, just like flu, having healthy individuals up to date on their COVID vaccine will also help those around them. Lastly, RSV. It's exciting. We hadn't had a vaccine, but there's a maternal vaccine that's been developed, showed efficacy that's, I think, will help for infants. Obviously, infants is where we see RSV impact the most. There's some upcoming clinical trials about to start to evaluate in children and in those with underlying conditions. That those are on their way. We're actually about to start participating in them. And then for RSV, there's this new monoclonal antibody. It's not a vaccine, but you can get one dose and prevent serious disease in normal, healthy infants. We're going to see how that plays out. So there is some things on the horizon to help prevent these. But the last slide I have, we have learned with the pandemic how we can really prevent spread of infections. Again, up in the left corner is vaccination. We know if we stay home when we're sick, that'll help prevent spread. But we also learn for respiratory infections, and likely some of the bacterial infections spread through the respiratory tract, like strep throat, group A strep. Masks work, man. They worked great. So I will tell you, like, I'm going to this conference. I won't wear a mask. I'm going to be around some of my friends. I'm vaccinated with COVID. I'm vaccinated. I'm not worried about flu. So I know I could potentially get it, but I know I'm safe. I'm not going to have bad disease, and there's medicines for it. But I'm not getting COVID on a plane. So when I get on I don't want to get it from someone I don't know, right? If I'm going to get it, I want to get it. I want to earn it the right way for me. So I wear a mask on a plane. I don't want it from them. So I think that's where we are now. We know, and I think in with people that are at a high risk, to help you get to that next layer of safety, we know masks will work. Again, we have more tools now around COVID that help. And again, cleaning and ventilation, all these things we know work, washing your hands. So I would still use these things to help us. So with that, I will stop. Here's just a picture of a lot of friends and family and people I love to work with, but I will stop sharing so you can just see me, and I'll answer the questions. Thank you, everybody.
Thank you so much, Dr. Newland. We have a couple questions in the chat that I will address.
Yeah.
First, our family is really good about infection prevention around our transplanted son, but the rest of our extended family is not. What can we do to educate them?
Yeah, this is a struggle, right? And unfortunately, I think we all felt this during COVID about how polarizing things, we all got pulled away, right? And so I can say what we have learned in regards of the vaccine world, because right, vaccination is super important. Vaccination and hand hygiene is core, and staying home when you're sick, right? So I think you got to keep engaging, and you have to keep saying this is so important for our son. And obviously, you know this better than I. You can say, look, well, I just can't have you be around them, especially right now. Especially because we're seeing a lot of influenza, we're seeing a lot of COVID. We know COVID's increasing right now. Like, I prefer you not be here because I am concerned. I think you have every right for that, because you know that your family and your son has a greater risk than others with that. And so I think that's okay. And I think you just have to keep engaging. It's hard, it's not fun, but the data has shown that by having continued engagement and not just pushing them away, over time, it does work.
Is there and I'll kind of piggyback off of that, is there a good place to obtain resources specific to COVID in transplanted children?
Well, I would say CDC is always just has the information that we know is trusted. It is vetted in the best way. I bet there's other great transplant sites. I know you guys with the transplant families will have great resources. And I know after talking with, Laura Danzinger, that you guys work with, she's having these places. So there's definitely those places there.
Okay. We have about 75 seconds left. So
I can talk faster.
What should I do if I see nurses and doctors coming in and out of our hospital room without washing their hands?
You tell them to wash their hands. You advocate. You get in their chili a little bit and you tell them they need to hear it. And I understand why you don't want to sometimes. I do, right? You feel uncomfortable. But by golly, you have every right. And they better listen. And if they don't listen, you need to take it to the patient advocate or whoever they report to. They need to know how important it is. They need to know it is. And if they give you a little defensive thing, says, well, could you just wash your hands again? I would prefer you do that so I can see it, because this matters to me. And by God, if they get defensive and you want to let me know and you're in St. Louis, I will go talk to them, because that's how important it is. We should be listening more to you, and you have every right. I want you to tell me. I want you, and they should be thanking you for that. Well, I like that one.
We're sending Dr. Newland to all of your
Oh, I
family.
got you. I'll be running right at him.
Awesome. Well, thank you. We have a ton of other questions and I'll get them to you so we can answer them offline.
Actually, Katrina, it seems like it sounds like we can run over just a little bit if you want to try and address some of the more important stuff.
Yes. Okay. We'll move on to some of these other really cool questions. So if my child is going to develop a resistant infection, if they do not take the full course of antibiotics, what is a risk if we miss a dose?
It's not a risk. I mean, here's the thing. If you miss a dose, fine. There's not going to be the risk. The reality is, as we use antibiotics, the bacteria are changing. The key is really get your dose, take it, and be done. And don't worry about those little things. Your child isn't going to become more, and your child's not going to be resistant to that antibiotic, right? So the key here is the person doesn't get resistant. It's the bacteria that does. So I think that's the key things. I wouldn't worry about that miss. It happens, right? Life's hard. You guys are doing so much. And so with that case, it's okay. It's okay.
And how do we resist the urge to overprescribe?
Well, this is always hard, right? And we're always playing the risk benefit. As you guys know better than I, right? Medicine isn't as black and white as we wished it was, right? There's so many levels of gray. So I think the best thing we can do is work together, understand our risk, but also understand there's important times when antibiotics must be given, and that's okay. But it's going to take these efforts, and it's going to take all these different things. We got to be able to diagnose the infections better. We have to be able to prevent the infections better. We have to develop more antimicrobials. We're going to have to do all of these things in conjunction, but it's going to take a societal approach. And it's going to take you guys even saying, I really think this is just a cold. I know them. We're vaccinated. I'm fine. I thank you for giving me the antibiotic, but I'm probably not going to take it because I feel comfortable in the setting. Easy for me to say, right? But you can have that conversation, and that might help the clinician say, yeah, I think you're okay to wait. And maybe I'm going to give you an antibiotic. You don't have to take it. But if things continue to worsen, then I think you can take it because we know that I'm now more worried about pneumonia. Again, conversation working together, I think, is going to be key for all of us in trying to address this need of using antibiotics appropriately better.
I'm going to combine a couple of these questions. Alexis Davis said, my daughter, 2-year-old with a heart transplant, has received her COVID vaccines and boosters and a regular flu booster. She received her RSV series for a few months after transplant. Why are there no boosters for RSV? And the second part of that question, another attendee asked, and how do you advocate for RSV vaccinations when it's hard to get insurance coverage?
Yeah, so here's the thing. So let's talk. So RSV. So there's not a vaccine approved for RSV. What there is this monoclonal antibody that your child will receive called polatuzumab. All right. So polatuzumab has strict criteria of when it's used because that cost effectiveness matters at a certain point. That drug, that medication, think of that almost as a therapy, but that we give early because it's the antibodies, right? It's these infection cells that our body makes when we get infected, but we give it to you passively so that if you see RSV might make you sick, but this is going to prevent you from getting really sick. So that is kind of where we are, and it's been harder. So I think this new medication I told you, nirmatrelvir, is 1 dose. Its approval is going to be in the infants right now, but you have to see where it's going to matter for people that are transplanted. The next step is true vaccination. Now that we have this mRNA technology that we saw with COVID, this is where I'm actually going to start a study hopefully in the fall, where they're going to be giving this vaccine, a true vaccine for RSV, to not only healthy individuals, but those who have immunocompromising conditions, so that we can say, hey, does this help prevent bad infection and true infection? Now, with that being said, as you guys know, we're probably 2 or 3 years away, maybe hopefully 2 years away from a true vaccine available. I think on that nirmatrelvir piece, I'm not sure where that's going to go, right? So I think you're right. That second part, where's the advocacy? Where is it? Well, I think our advocacy is this, guys. I think the advocacy is we need to stay up to date on what nirmatrelvir is going to mean for the immunocompromised. Where is that going to be in the discussion, in the approvals, and how it gets out, how the insurance companies are going to approve it? We got to keep an eye on that, because there's a lot of people. I was just at a conference this week that says they think it's going to get to where we give it to newborns as they're coming out of the hospital, even if you're healthy. That's new. And I'm still not convinced. I'll be honest. I'm like, really? So I think we got to just stay up to date. We got to be paying attention, seeing what that matters. Because for you all, I agree. I think my colleagues say, yeah, if we can get an RSV vaccine or the monoclonal antibody to help you guys prevent some really serious infections, especially for like lung transplants, especially those where it can impact most, we got to be there and ready. So hopefully that answers. I know the ID in me gets go rambling, so I started to ramble so much. I'm just not sure where it's going to go.
Well, we enjoy your rambling. I'm gonna do one more. I think it's really relevant to a lot of the experiences that we as parents are having. My son's GI doctor wants my 16-year-old son to wear a mask at school. He's been masking for 3 years and frankly is sick of it. What are your thoughts on him not having to wear a mask at school? Yeah, I mean, here's the thing. I'm now of this ilk to say, hey, look, all right, you look, I'm with your son on this. I hate that damn thing. Our hospital on March 22nd said it could be optional. I was like, woohoo! And I'm an ID doctor, right? Like, and I was seeing these non-ID people going, you're not wearing a mask. I'm like, no, because I'm tired of it. I like to see faces. I like to be in presence with people and having conversations. Now, of course, I'm going to wear it if family wants me to wear it. I'm going to wear it in certain situations. I'm definitely going to wear it if I'm going to go out and have any inkling of a runny nose, even if I'm COVID negative. Like, there's all these things. Now, for your son, you know, I understand why your GI doctor would say that, right? The most conservative approach is to wear a mask. It is going to prevent you from having any of these illnesses. Do I think your son, who has a liver transplant, could go without wearing a mask? Yes, I think you could. I think you have to take in that there is a risk of COVID. We do have a medication called Paxlovid that if your son would get it, I would be giving, because they're 16. So they are approved to receive it, though we don't have the greatest data for this age group and they want to get more, but it is approved for them. We have therapies in the hospital, but there is the risk, right? There is a risk that they're going to come home with a runny nose and cough. It is going to be there. But let's be clear, your son was going in the face of that with influenza. So you do everything you can to provide everything necessary. If they're vaccinated for flu and COVID, and they don't want to wear a mask, and you're okay with the risk of coming home with some runny noses and coughs, I think it's okay. I think it's okay if that's the risk that your family wants to take, and you just take that in. And if he wants it, you just say, hey, look, this is the situation, guys. And I think that's because, I don't know, if I was a 16-year-old boy and you've been making me wear a mask and none of my friends are, I'm ready for it. And I might, and he, you know, you and I both know he might not be wearing it, though he probably listens better than I did, or my son does. And I think that's what you do. And it's okay. Okay. Joseph, are you okay to answer the rest of these offline, or do we keep going?
You guys rock. It's up to Dr. Newland, because we're in a break. So.
I'm happy to do more if you want, Katrina.
Okay, let's keep pushing.
Yeah.
Is my child going to develop oh wait, no, we asked that one. Sorry.
Yeah, I think we did that one.
Yeah, we did that one. When my daughter got her liver transplant 17 years ago, we were told that, this keeps moving, sorry, that she was unable to obtain erythromycin and azithromycin. Is that still the case? I don't know the answer to that, Ms. Shimi. I'd have to look. I think you could still get it. I don't recall what the rationale was for not getting, unless there was some kind of, it could be. And I would have to look. It might have been on what immunosuppressant, if there was some drug interaction potentially, but I would have to double check. I have a great pharmacist I'll reach out to, and I'll follow up and get back to you on that. Fantastic question. And another one, why does my child get prescribed amoxicillin sometimes and penicillin other times? What are the differences between these medications? Yeah, so amoxicillin, so they're similar. They're very similar. Amoxicillin will treat a few other bacteria like E. coli sometimes. People have often given amoxicillin, it's easier, it's twice a day, it tastes better typically. But penicillin, when it's used, is sometimes used the exact same way for the same types of infections. Most of us have done a little bit more amoxicillin, but again, in that case, it's likely okay. And sometimes they'll use penicillin as like a prophylactic, like let's say to prevent endocarditis in some cases. So that's kind of the reasons. But again, I wouldn't worry about those two things. They're doing the same thing. Awesome. And if a child has an allergy for oxycillin, is it worth asking to challenge it? Who is the right specialty to talk about this?
Yeah, I would say this, right? So if someone has an allergy to oxycillin and you guys saw it, it is worth really looking at and to consider seeing an allergist to see if it's really an allergy. Because here's the deal. If someone sees on your chart, on your child's chart, oxycillin allergy, they ain't even going to give you any, it's just like a penicillin allergy, right? They're not going to get, many of them are unlikely to give you a cephalosporin, which, look, cephalosporins are super important. Actually, this is in this category of beta-lactams, which has a lot of different drugs we use, meropenem or the carbapenems, a lot of the cephalosporins. So I would reach out to an allergist and say, hey, look, I really want to see if this is a true allergy, and tell them about the reaction, and then see if you can get a challenge, because you know how important it is for future therapies.
Okay. And last but not least, there's a suggestion in regards to insurance coverage. If your insurance comes through your employer, depending on the size of your employer, talk to your HR department. I work for a large organization and I'm blessed to have an excellent health insurance plan. But even with that, I've had some issues because of our size. We have a fairly large HR team and they have staff who are able to advocate with and can override decisions by insurance. So that is wonderful advice because we all love to deal with insurance on the back end. Those are all the questions that have come through the chat.
We did have one comment or question that came in through chat into Q&A, but I just wanted to get this in because I think it's key. Yes. Margie Jones was asking about would the mask recommendation be any different for a transplant patient with lung disease, specifically kidney and pardon me, I'm going to butcher this, bronchiectasis.
Yeah, you got it. I think again, those people may worry me the most, right? If I had a lung transplant with, the immunosuppressant they're needing, and we know how COVID likes the lungs, I think you're right. I mean, I think you now have the risk of serious disease goes up another level. And so you could say that, yeah, I'm always going to be for, if you really want to make sure you prevent, and those that have the greatest risk, the best way is to wear a mask. My parents are over 70. They're vaccinated, they're going to be fine. I think that it's somewhat mitigating. We have some things. So if you have this 20-year-old kid who has a lung transplant from CF and they really want to do it, I'm like, look, it is risky. I'd make sure you're vaccinated. We have all these things in place, but your best chances of to prevent yourself being in the hospital is wearing a mask. So I think you're absolutely right, Margie, that the context does matter, and your risk, depending on what your transplant is and what your disease is higher than maybe someone that had a lung transplant on immunosuppressant that has normal, healthy lungs. So yeah, it's a very good point. It's a very great point.
Okay, Joseph, was that all the questions?
Yes, thank you.
Okay, perfect. Thank you again, everybody. You can give you a little bit time left on your lunch break. And then we have the session about transition for pediatric to adult care. So thank you so much for your time and attention. Thank you, Dr. Newland, for engaging in some great conversation. And by that, we'll end the session.
Yep. Thanks for having me, guys. Super big honor. I really appreciate it. Have a good one.